Next, we have the panel discussion on intraoperative hypotension, which we face very often in our day-to-day clinical practice. Several times you're confronted with a situation where you do not know whether you need to give vasopressor or you need to give fluid or whether it's... So, to clarify all the doubts, we have an excellent expert panel. This panel will be moderated by Dr. Sunil Pandya, as Dr. Mahesh Vakamudi could not join us today. And it's got eminent faculties. May I call upon Dr. G D Puri, Professor and Head Department of Anesthesia at PGI Chandigarh, Dr. Naman Shastri from Ahemdabad, a legend in cardiac anesthesia, Dr. Senthilkumaran, Professor of Anesthesia from Northampton, Dr. Karunakaran Ramasamy, Professor of Anesthesia from Northampton, Dr. Miodrag, our WFSA Educational Committee Chair from Serbia. Yeah. So we would request Dr. Divatia to join this group and Dr. Arvind to join this group. Okay, so Dr. Divatia to join the group, please. Over to Dr. Sunil Pandya.
After the emotive and the factual sentiments expressed by Kalki Madam, I think it was really an eye-opener for us. Thank you, Madam, for giving an insight into what a transgender is. Thank you very much. And we all support for the cause. We move on to the panel discussion. Yeah, it is very difficult to replace Dr. Mahesh Vakamudi, but I shall try to do my best because we have the expert panelist. Before we move on, let us start off with this question, if I can have the things on. How many of you actually know the baseline blood pressure of your patient before initiating anesthesia? Number one, answer number one, yes, always. Two, no, not sure. Well, at the end of the panel, you'll know the true answers. I have the expert panel of various specialties, and I'm sure it will do justice to today's topic. So let us start off with the basic thing. How do we define intraoperative hypotension? Is there any universal definition? May I ask Dr. Karunakaran? Is there a universal definition for intraoperative hypotension?
There are only 140 definitions which the postgraduates have to remember to answer in exams. No, there is no universal definition. The traditionally accepted definition is if you know the baseline blood pressure, you accept 20% less than that. But I think we are moving ahead from the concept of relative hypotension to absolute hypotension. And the second concept which is being introduced is the duration of hypotension. So what is absolute hypotension is you stick to one map number, because previous studies have shown that a lot of people don't know what the baseline blood pressure is. So the mean arterial pressure of 65 millimeter mercury is being kept as a standard, and anything below that is classified as intraop hypotension.
So with the definition, does one size fits all? What about the special consideration in neonates and geriatrics, Dr. Miodrag?
If I can just add up to previous topic that I think that it's very important, and it's in literature very obvious that comorbidities are also very important. So related to the second topic, no, I think we reach that moment that we are aware that there is no one size that fits all in any other places or areas of medicine or in life, so not in this specific topic. And there are certain differences that are needed to be observed as far as neonates and geriatric patients are concerned. So in latest literature that I have found from Ohio Cleveland Clinic or from some other very renowned and prestigious institutions and researchers, that actually there are a lot of signs that neonates, or actually pediatric population less than 6 months old, are more prone to this intraoperative hypotension, and that pediatric patients less than 2 months old can be much more developed some postoperative problems in various fields. So they are the most vulnerable English term wounded group. And of course, as far, I'm not a pediatric anesthesiologist, but this is something I found in literature. And in geriatric patients, there are also great number of reasons to be very cautious and not to follow completely the baselines that we defined as absolute or relative. And the number of their comorbidities are that we should take in consideration. And this is the reason why a great number of those patients has to be treated differently. And number of postoperative cognitive or cardiovascular or other problematic situations are probably the main reason that can occur after unhandled well this hypotension, intraoperative hypotension.
So the message that is given is one size does not fit all. You need to have different variables at different age group. Which one is important to measure? The systolic blood pressure, diastolic, or mean blood pressure? Dr. Puri or Dr. Naman, anybody would like to take?
I've been sitting across the table asking questions to my students. It's very easy. It's very difficult to answer. Well, as a cardiac anesthetist, if you allow me to handle some of the other questions also within this question. Our perioperative management or management in critical care is basically to ensure that the oxygen delivery to the tissue is more than what is needed by the. So, and the blood pressure, the hypertension, I always say that these are the numbers. Whether the numbers are correct or incorrect, what you're seeing, well, if I am measuring from the radial artery immediately post-bypass, it may not be the correct thing. If I'm measuring non-invasive blood pressure in a patient who is having some subclavian artery stenosis, that's another. So the most important thing is ensuring the adequate oxygen supply. But definitely the blood pressure is one of the indicators for the normal, anesthetists who are not doing any invasive or the sophisticated monitoring of tissue oxygen monitoring, which should be the actually what is needed. And coming back to systolic, diastolic, or mean, each one is important. But if somebody asks me one pressure, I'll say mean is important. But if you're going to treat hypertension, then you have to see whether systolic is causing rise in the mean or whether diastolic causing rise in the mean. Then my management is going to be different. If the diastolic pressure is high or the systolic pressure is high, my drugs will be different. But if you're talking of perfusion pressure, the mean is the thing which I want to know. And as Dr. Sabha said, 65, in general, 65 to 70 is the limit beyond which I will not go unless I have other measures to assess whether this pressure is adequate to provide good mixed venous oxygen tension or the tissue oxygen saturation or prevention of the lactate metabolism. So mean is the one number which I'll say.
Can I just add? So the only other thing I'd like to add is that the diastolic is important because that determines the coronary perfusion pressure. And if the diastolic is very low, then I would definitely be worried about a low diastolic pressure, say below 40 or 30 or something like that. So that usually often doesn't happen in anesthesia, in the general course of an anesthetic. But if there is some excessive vasodilated state or a complication like maybe anaphylaxis or something, then, then the diastolic pressure also needs to be treated. Of course, the mean will also be low at the same time, but a low diastolic pressure is also something we need to worry about.
The duration of hypotension, is it relevant, is it transient versus a little longer duration? What do you feel, which is the time limit? Is there any time limit like, okay, 15 minutes of hypotension is acceptable or 5 minutes also is dangerous? Can you throw light on that?
Actually, there is only one literature who has come up with the giving idea about durations, that particularly this is implied to the older age group, not the younger age group, that those patients who are more than 65 years of age and mean pressures, the target mean pressures for that particular patients, if the 1 minute more than if this hypotension remains for 10 minutes, after that every 1 minute the chances of post-operative morbidity and mortality increases by the 3.5%. So 10 minutes beyond, every minute carries the high risk chances of the morbidity and mortality. This is particularly implied to the older age group of patients where we have associated hypertensions or coronary events or any other end organ damage. Otherwise, in younger age group, they say at least should not be the more than 10 minutes of the hypotension acceptable.
So profound hypertension for a longer time is, it's better to be corrected judiciously and rapidly. Yeah.
So there was a large analysis for retrospective database, about 20,000 or maybe slightly less than 20,000 patients. And they found that they looked at various things and they looked at the threshold or what, but to cut a long story short, if your systolic blood pressure was less than 70 for more than 5 minutes, or your mean was less than 50 for more than 5 minutes, or your diastolic was less than about 30 for more than 5 minutes, was bad, right? Or a drop below more than 50% of your of the baseline blood pressure was also bad. But this was predicting mortality. Morbidity would have been predicted by maybe even lesser magnitude of drops. But this was, if you have a systolic less than 70 for more than 5 minutes, it actually predicted higher risk of mortality in these patients. So
the adult, you're talking about an adult person.
Sorry? In adults. This was in adults.
What we see on the surface is much different than what happens underground. I'll say the hard endpoints normally when you in any study is mortality, and you need not have to die to say something is good or something is bad. In the morning there was some lecture on the neurotoxicity, pediatric neurotoxicity. Well, who knows what happens? This is what was in a long run. And as he said, that in geriatric this is much more important because it becomes obvious much quickly. Because they are vulnerable, the reserve is less. The brain is already damaged by the onslaughts of 60, 70 years. A little more can, at the watershed areas, can really play havoc. But what happens to the children or this thing, we are just imagining that everything is all right because patient is walking. So I am not aware of any study which has shown that in addition to what he has said, where the intraoperatively hypotension and low BIS was supposed to be a bad outcome indicator. But I won't tolerate hypotension unless I find it difficult to manage without using extreme measures. I will try to keep the pressures, as somebody said, the baseline, within the baseline, and maybe on the higher side if my endpoints are different.
Yeah, Dr. Senthil.
I agree with Dr. Puri on that. And also, earlier talks in the day had referred to incidents of myocardial ischemia and major myocardial events. The nature of these events are not as it would appear in the general population. They are very silent and occult and definitely have a major contribution to perioperative morbidity, if not mortality. And of course, the relative numbers which we were quoting, morbidity is a big additional cost to healthcare. And in relation to the enhanced recovery process, which previous speakers have alluded to, hypotensive episodes and silent myocardial ischemia are significant contributors to longer lengths of stay in hospital, cost, and poor patient outcome.
Now, one of the important pitfalls is how do we measure hypotension, or how do we measure blood pressure? Does it matter how we record the blood pressure? The fallacies of conventional mercury manometer or non-invasive blood pressure monitor? Dr. Puri?
Well, I already told you the size of the cuff, you know, the type of the manometer which you are using. There are a lot of fallacies in that. So one number is not good enough to satisfy me. That's what I say. And the younger population is here. I just, before I come to this, how it measured topic, I just want to stress to the younger generations the importance of the normal blood pressure. People, when I was growing as an anesthetist, I saw myself patients, you know, coming out, even keeping mean systolic pressures of 70 and 80 under spinal and other things, and say, oh no, it doesn't happen. Well, the urine is being flown, everything. Till I saw a critical, did a critical review of my patients in the vulnerable patients, and I found having delirium, abnormal behavior later on. Who knows? Who does the MRI post-operatively in these patients? You know, so I will advise: do not take the low blood pressure lightly because the patient is fine. People say, "What happened?" Well, patient was talking, then suddenly happened something. So don't wait for those hard marks. You go for soft markers also. Now coming back to the blood pressure, how is it measured? If it's a cardiac patient, I'll measure invasively. If I need a critical, I don't want even a 1 minute drop in blood pressure. As I said, ischemia can lead on to arrhythmia, and then I don't want to wait for 5 minutes, so I will need invasive definitely. If I'm doing a cardiac surgery, I'll go as central as possible, especially post bypass. And rest is I'll keep calibrating my the non-invasive blood pressures regularly with the standard mercury manometers, so that's the gold standard to me.
Dr. Naman, can you throw light on invasive blood pressure monitoring? How do you validate hypotension that occurs, that you see with NIBP and any other thing that is more sensitive or specific to say, yes, this reading which is displayed on the monitor is correct?
Yeah, particularly it is very important thing actually when we are using invasive monitor, whether we are measuring central venous lines or arterial line, that if you have the continuous infusion line, the pressure bag, and if you generate a 300 millimeter mercury pressures to that bag, and you just pull the flushing device, and then you will always find the square waveform. And once patient gets this square waveform, and immediately you releases, there will be the 1.5 oscillations to it. So if you have the multiple oscillations after the releasing that flushing device, it means patient is having the hypodamp. Like patient's overdamp means that you may have the overestimation soft arterial waveform. So if you have the multiple oscillations after releasing that flushing devices, will lead to the more overestimations of the pressures. But when you have hardly any oscillations, means patient will have the underestimation of the blood pressures. And this usually happen in many cases. Suppose patient is having the air bubble inside the line or the pressure monitoring line, then also you get some problems. Or patient is having the hyperdynamic circulations, then also you have the change in the damp of the waveform. So the validation of before initiating the invasive line monitoring, zero calibration to the atmospheric air at the level of phlebostatic point, and then calibrating the complete technical stuff is very important for better outcome. That is more matter in case of pediatric population as well.
Dr. Karunakaran or Dr. Miodrag, yeah.
Thank you. I absolutely support those words, and I agree. I just wanted to add that that refers also to all other patients. For example, I am dealing with the major traumatized patients working in a major emergency hospital in my region, and of course there are the needs sometimes to control the hypotension for some of the situations, but for example, for traumatic brain injured patients, there are major need to control invasively, if not intracranial pressure, then for sure calculate somehow intracranial and mean arterial pressure to allow enough oxygenation and perfusion in central nervous system. Also, the perioperative period is very important, so I would stick to invasive blood pressure as priority, and the non-invasive later on, maybe on the ward. But high dependency unit and ICU for sure should be invasively monitored, those kind of critically injured and ill patients, because as we know, each minute counts, and from periodical measurement of non-invasive blood pressure, we cannot get the real framework. Thank you.
Yeah, Dr. Karunakaran, are there any important indicators of perfusion other than blood pressure? Because ultimately, blood pressure is a surrogate marker for adequate perfusion.
Yeah.
So
it's only a means to the end. The perfusion is the ultimate aim for pressure. So first is we should look at the patient, feel. End-tidal carbon dioxide is another surrogate marker of how well the patient is perfused. And as already mentioned, lactate measurement is another useful way of checking if the patient tissue is getting oxygenated or not.
Yeah. Any other clinical pulse volume? Any other simple bedside monitor? Urine output. Urine output. Yes, that's one of the best clinical indicator of good cardiac output. Toe temperature as a urine output. If toe temperature is good and urine output is more than 0.5 ml per kg per minute, that means at least perfusion is adequate. Now, this is just to summarize what our panelists have said. How do we validate hypotension? First thing is always trust what is shown in NIBP. First treat and then subsequently suspect if the readings are wrong. Oversized cuff may underrate blood pressure and vice versa. And more importantly, just palpate the large vessels. A carotid pulsation at least indicates systolic of 90, brachial is about 80, and femorals of at least 60 millimeters of mercury. And Dr. Naman has highlighted the checking of arterial line and the damping, over-damping effects. And look at the plethysmographic signal on the pulse oximeter. That also is a good indicator of perfusion. So surrogate markers are also equally important. You just mere reading on pulse oximeter is not important, but check the strength of the signal on pulse oximeter. That also gives us indirect marker of perfusion. And of course, end-tidal carbon dioxide is a good cardiac output monitor. Now we have a preoperative hypertension coming to the phase. What are the predictors of perioperative hypertension when you do the patient or having a patient during PAC checkup? Do you say this is a patient is a high risk for perioperative, intraoperative, postoperative hypertension? Dr. Puri, again, you begin.
I'm very favorite student of you, you know. Well, predictors of perioperative hypertension, first thing is any patient who is having hypertension, that is the most important to me, that he is going to, because is vulnerable to any of the drugs which we normally give to vasodilator because of the constricted volume they may be having. So inadequate preoperative hypertension control is one predictor of good perioperative hypertension. Then the type of surgery, where, you know, if you're going to have blood loss, etc., where the surgeon is going to, like I am always worried about the surgeon, because when he's going to press the heart, when he's going to put the hand under the diaphragm, you know, these are things, they're the patients who are, so those patients I would like to put an artery line beforehand, like. And it's not only the predictors of perioperative hypertension, maybe the next question is coming, which is the most serious patients who are, where we are bothered about this. And for me, the critical aortic stenosis and, you know, left main disease and, you know, coronary artery disease, patients with cerebral ischemia, patients with recent stroke, they are the patients where we'll never like any pressures to budge from the baseline. Rather, I'll try to keep on the side. I don't know, Dr. Devetia may be able to add more through the predictors of hypertension.
Yeah, I mean, not much, but but I think that's very important that the hypertensive patients are actually the most prone to hypotension during surgery. And one is the abnormal reactivity of the hypertensive patients, plus the drugs that they take, especially if they've been taking ACE inhibitors and they've continued those sorts of things. Patients who've got some preoperative, who are heart disease of any other sort of, who got low ejection fractions, history of congestive cardiac failure, they would obviously be prone to intraoperative hypotension. Patients who are likely to bleed or who have been bleeding or who have been dehydrated for some reason, patients with intestinal obstruction, etc. Those with the poor intake, like esophageal tumors, they would probably be prone to hypotension. The one thing I want to add in the previous talk is that, we talked about indicators of perfusion, and of course, mean arterial pressure, cardiac output is mean arterial pressure arterial pressure is cardiac output into SVR. So it's using it as a surrogate for cardiac output. But at the same time, blood pressure itself needs to be defended when it's low. And for example, sort of example Dr. Puri was giving, maybe an elderly man having a hip replacement and he's given a spinal anesthetic. His BP may drop to 70 or 80, and that may cause significant damage even well before his lactate is elevated or anything might happen. So I think it's important to defend the blood pressure initially. We then need to figure out whether the vasopressor or whatever therapy you're doing is actually increasing cardiac output, or whether it's vasoconstrict too much and you're decreasing cardiac output. That's the second step. But I think especially in vulnerable patients, we need to defend blood pressure. And I think many of those cognitive dysfunctions and what he said, what happens after 1 month and 3 months and patients losing their memory and that sort of thing, may be because of not defending the blood pressure early. If the perfusion indicators are bad, that's obviously very bad, but I'd suggest that in vulnerable patients, even a drop in blood pressure with normal perfusion parameters may still not be a good thing.
Yeah, Dr. Senthil.
Okay. I just wanted to add on to the indicators of perfusion. In my clinical practice where I do microvascular surgery, anesthesia, the core to peripheral temperature difference is one very helpful tool, simple to do, and a very helpful tool to assess perfusion to all organs. If we can get the core to peripheral temperature difference as close as possible or as little as possible, we're pretty much reasonably sure that the vital organs are reasonably perfused as well. And the other aspect of coming to this question about predictors of hypotension, I think among the cardiovascular disease is the first initial suspect. Poor control of blood pressure is initial suspect. But also diabetes and autonomic neuropathy, patients having end organ failures secondary to diabetes are highly susceptible to perioperative hypotension and swings in blood pressure. And that's one thing I would like to add.
Yeah, Dr. Karunakaran would like to emphasize on the implications of preoperative medications that can have effect on intraop and post-op hypotension.
I believe most have been covered. Just one study I would like to mention, which is the VISION study, which has come out recently, looking at ACE inhibitors and angiotensin II inhibitors. There are two groups, so the endpoint is they need to be stopped to avoid intraop hypotension. Otherwise, there is increased morbidity and mortality. And the second point is they need to be restarted as soon as possible after the surgery. And these are the two take-home messages from that.
Yeah, never stop beta blockers, but stop ACE inhibitors and ARB inhibitors. In fact, we have seen several occasions that cardiologists do not stop any antihypertension. They'll be on various, at least one or two ACE inhibitors. But I think we need to have an open communication with the cardiologist saying that, okay, at least let us stop ACE and ARBs at least day before, and then continue beta blockers and other short-acting antihypertensive agents. Now, does it influence outcome? Like if you have a profound intraoperative hypertension, already we have touched few topics, but does the variability of MAP, do they affect morbidity and mortality? Especially young adults and geriatric. Geriatric, of course, we all know, but let us take a scenario of young adults and middle-aged.
I'll still refer to one of the study which I vaguely remember, but the thing was that if the mean pressures remain for longer period of times, less than 60, it is, I'm forgetting what was the age group of that, but I think the more variable is the outcome is going to be bad. I won't be able to give you an answer whether the mortality is increased or not. But yes.
I don't have anything to add.
Actually, I'm very happy that the emphasis on which I put my lectures in the morning, everything is going into the same direction, which I narrated at the end of my couple of slides, that in perioperative hypertension it is more concerned when a patient is going to the hypotension than the hypertensions. So yeah, that even it has been already proved that the labile hypertension intraoperatively, labile hypotension or labile variability of pressures definitely changes the outcome, because the autoregulations, and particularly in cases of diabetic patients, this is more common as compared to the others. So as Dr. Senthilkumaran has nicely said, and the diabetic patient has got more chances of this mean arterial pressure variability. So definitely, so in those patients, managing lability is more important than targeting some particular number. So definitely it makes a change in the outcome. The intraoperative hypotension and
some
perioperative.
Facts about perioperative myocardial ischemia with hypotension. The recent studies, if you can throw some light on this.
Yeah, it is definitely, it has got direct relations of intraoperative hypotensions and perioperative MI. Particularly, again, this is more common in the very high old age of patients, where patient can be having the underneath diabetes along with that atherosclerotic diseases, which we may never know. Patient could have the silent angina also. So the peripheral vascular disease with coronary artery disease, these patients cannot tolerate the intraoperative hypotension as compared to the other normotensive patients. So definitely it has got direct relations. Particularly, as Dr. Divetia sir has said, that a diastolic pressure that also goes down intraoperatively when patient develops hypotension. So as coronary perfusions mainly rely upon that. So augmenting the diastolic pressure. So in those cases, adding the vasopressors like norepinephrine and vasopressin is more important to tide over the crisis of the fall in the hypertensions. Now that is the reasons why the guidelines has suggested there is only the indication of nitroglycerin is very less in intraoperative managing the hypertensions, because by giving the nitroglycerins we are inducing tachycardia and we are reducing the diastolic pressure, and so the coronary perfusion hampers a lot with addition of a nitroglycerin. And particularly in intraoperative period, the MI is usually common, may not be inside the operation theatre, but within the third day, second or third day is a very dangerous day where patients can have the chances of perioperative MI. So naturally the intraoperative hypertension incidence and the continuous hypotensive durations and perioperative MI is very high. So should be targeted aggressively.
How about stroke and postoperative cognitive dysfunction, Dr. Senthil or Dr. Karunakaran?
To be honest, I don't have exact data, but for sure it's associated with the greatest number of elderly patients. And of course, as I know the agenda in next few minutes, it will be related to some of the positioning of the patient and to some diversity of anesthesia techniques more. So for sure post-operative cognitive problems are occurring, and it's associated with hypotension that it's not recognized in time and not corrected. And I support the proper and timely in time use the vasopressors and oral medications that could prevent that problem. And even so, certain number of post-operative cognitive problems are occurring, and then that can be attached to some other problems, maybe not to hypotension, maybe to some other comorbidity or some special needs or circumstances that can occur. I mentioned comorbidities at the beginning, and it can be that person was not properly evaluated at the beginning. We heard during the morning that some of the patients were not seen on the ward by anesthesiologist or not completely evaluated, and then some of potential already existing diseases can be added to these post-operative problems.
I'll just add to the intraoperative hypotension and stroke.
Yeah.
That we know that.
Can you have the mic?
Yeah, we know that the requirements of the blood flow to the organ, the brain, is like 50 ml per 100 grams of the brain tissues. Now it has been proved that if the mean arterial pressure goes down to more than 2/3, so this 50 ml per 100 gram goes down to the 25 ml to 30 ml per 100 grams. And if it goes down more than 50% of the standard mean arterial pressure of that patients, then patients, they start developing the cerebral hypoperfusions related changes, and it has been even proved with the cerebral oximetry also. And so beyond 15 ml, beyond 15 ml per 100 gram, if it goes down, then chances of the stroke and post-operative cognitive dysfunctions is very high. Even in our cardiac surgery, we have seen that the patient remain persistent hypotensive intraoperatively. They usually go into the delirium quite often. And sometimes, most of the times, this delirium is unnoticed because there are the hypokinetic deliriums and hyperkinetic deliriums. We always look at the hyperkinetic, where patient is making fun out of in the ICU, is shouting and all. But many of the patients, they just quietly lie down, doing nothing, not responding very well. They are the hypokinetic deliriums, and that probably because of the perioperative hypotension. That could be one of the reasons of that.
And the duration of hypotension and incidence of acute kidney injury, Dr. Divatia, if you can just throw some light on this.
So again, I can't tell you the duration of hypotension, but intraoperative hypotension is a very important predictor of post-op acute kidney injury. Even regarding hypotension and stroke, when you have patients with coronary artery disease, which is rampant nowadays, and very often we are happy that the coronaries have been stented and the heart is normal, but they may have carotid plaques, and they may be having a reduced blood flow through the carotid arteries to start with, and even a little cerebral hypotension in these patients can actually lead to predisposed to stroke. The problem is that no one knows how much hypotension for how long is bad for the patient, right? So that's the only sort of this thing. So I think, so the bottom line would be keep the blood pressure and cardiac would as close to normal as for almost throughout the procedure. And the only other thing about hypotension and acute kidney injury is, of course it depends on the cause of the hypotension, but if the hypotension has been associated with fluid loss or bleeding, and then we have to be very careful about what we give in the post-op period. And in this era of multimodal analgesia, we need to be careful about the NSAIDs and so on that we give these patients. So hypotension, of course, contributes, but we must make sure there are no other contributing factors from our side in the perioperative period.
Thank you. I request Dr. Arvind to answer the last question.
I just ask Dr. Divatia this question.
Yeah.
Is a good renal urine output during the intraoperative phase an indicator of adequate renal perfusion? And would that actually preempt an acute kidney injury?
I think urine output either way, neither a low nor a high urine output would be a good indicator of renal perfusion. It depends on, so one thing is a low urine output does not necessarily mean the cardiac perfusion is poor, because especially in the perioperative period, you've got liberation of all your ADH and renin-angiotensins, which sort of tends to preserve the water, and therefore urine output may be slightly on the lower side. A reasonable urine output is some indicator of the adequate renal perfusion, but I don't think in the setting of hypotension, you can take it for granted that normal urine output means everything is absolutely normal. Some of the drugs that you give can actually produce a high output renal failure. So I think, but a normal urine output is more reassuring than a low urine output. So I just put it at that.
Yes,
I want to add one thing is intraoperative hypertension associated with anemia. is again a major contributor for the intraoperative MI as well as multi-organ dysfunction.
The oxygen
after the
delivery is
surgeries.
impaired, yes.
So the intraoperative hypertension with association of anemia is also one of the
Risk factor.
morbidity combinations.
Is Dr. Arvind around? I just saw him sitting here. Dr. Ketan, would you like to answer this question? Hypertension in obstetrics, should it be looked at differently?
Definitely it has to be looked at differently because you're looking here at two lives, and what you can do is that you can measure the maternal blood pressure, but you're not able to actually measure the fetal perfusion. So it is extremely important that you treat this hypotension critically, and in the morning Kajal and Madam has already debated on this issue. So this definitely has to be looked differently and more critically, and you have to try and maintain the mean blood pressure preoperatively as close as possible in order to prevent any fetal hypoxia.
Even in students with severe preeclampsia, don't try to maintain BP of 120/80, at least 140/90 and above 150 should be maintained, because aiming of BP of 120/80 or 120/90 in a preeclamptic parturient may reduce fetal perfusion, so it may cause fetal distress. So maintaining a map of at least 75/80 and above in a parturient with preeclampsia is mandatory. Subsequent slide, yes, type of anesthetic and hypotension, does it influence? Dr. Karunakaran.
Certainly there is evidence that regional anesthesia has got advantage.
Yeah, continue. Actually, we have. I have been asked to reduce the duration to 40 minutes, but another 5 minutes we can. Yeah, thank you.
Answer first.
Yeah, please.
Yes, there is evidence in some specialties that regional anesthesia is, produces definitely better outcomes in terms of morbidity and mortality compared to general anesthesia due to avoidance of intraop hypotension. This is more common in vascular group of population.
Dr. Senthil, positioning and risk of hypotension.
I'll just speak with the hat of the regional anesthetist, and my work involves a lot of upper limb surgeries and joint replacements for the upper limb. And patients are sat in B-chair position for most of the operation, lasting up to 3 to 4 hours. So my combination of regional anesthesia with general anesthesia, because sometimes muscle relaxant is required for these procedures, I do very much worry about these patients because of their existing comorbidities, extremes of age, and although about 4,000 patients in recent studies which said there's no evidence of stroke, my own experience is that the evidence of postoperative cognitive dysfunction is pretty significant, and I do take great precaution to measure the blood pressure at the level of the neck, if not higher.
Position, any particular emphasis, prone or sitting position?
Well, as an anesthetist, I would prefer a lying down position, definitely. But I think we need to accommodate the surgeons who sometimes are very disoriented if they ask them to do it on lateral position, even if the patient's situation so demands. And it's a very tough balancing act to follow. And sometimes I need to use some continuous vasopressors in order to maintain perfusion pressure.
What about the beach chair position, which the orthopedics people might be using in your setup, because you said orthopedics anesthesia.
Indeed.
So are you worried about that, and what pressure you
in those situations, I try not to drop the mean arterial pressure less than 10 to 15% than the baseline measurements. Simply because I have nothing to lose if I have the pressure slightly higher up. But I tend not to use too much vasopressors. I would want to use it as it when necessary. And often lightening the plane of anesthesia with the combination of regional anesthesia tends to sort out the problems most of the time.
Well, I just want to add to you put up this street pressure perfusion. We have already discussed a lot. going back to the previous thing, and I'll say that we have been talking of the pressure, also about the perfusion, and we're two contrasting organs, the brain and the kidney. But no doubt the perfusion pressure is important, but the kidney cannot survive the low flows. They mean if you have a given pressure maintained with vasoconstriction, the kidney is going to fail, while the brain will still survive because of autoregulation. So we need to have good pressure, at the same time good output, not a vasoconstricted, and as already said, about the good hemoglobin, so that the good oxygen supply to the tissues is there. So just one.
Beyond routine drugs for treating hypotension, is there anything new in the horizon? Anybody? Dr. Senthil or Dr. Karunakaran?
Before that, can I just, since I have the mic in my hand, talk about pressure and perfusion?
Yeah, please.
So I entirely agree, especially in this era of ERAS and restrictive fluid therapy, it is quite commonplace to give a little vasopressor in the event of a little bit of hypotension, especially if it is neuraxial block induced, which is fine. So essentially what is happening is we have a certain venous capacitance, which may be increased when you give a neuraxial block, and it is fine if you give a little bit of vasopressor that returns to the circulation. But in the face of ongoing fluid loss, giving excessive vasopressor may then be detrimental and will drop the cardiac output. And like Dr. Puri has been mentioning from the beginning, we are treating pressure, but we have no clue about the cardiac output. And we now are going to have non-invasive cardiac output monitors. There's something from Edwards is going to come out with a device which is already there probably abroad called ClearSight. And in low-risk surgeries and moderate, medium-risk surgeries in whom you don't have an invasive arterial line, even that may give you some idea about the cardiac output. And in higher-risk patients, of course, you can do non-invasive cardiac output monitoring using many of the other sort of devices which we have. So I think at some stage it becomes important to use these devices to know both the blood pressure as well as the cardiac output. And then, of course, the downstream mediators of perfusion like lactates and so on.
Any newer drugs on the horizon for treating blood pressure? Dr. Senthil or Karunakaran?
I think we heard in the debate, the old drugs are coming back.
Yeah.
So
the low-dose norepinephrine, as was mentioned in the morning pre-lunch debate.
So yes. Noradrenaline is a very good drug. It's very often thought of as a vasoconstrictor, but also has a good amount of beta activity. So it does have inotropic effects as well. That's amongst the vasopressor, I think that would be. There are other cardiac drugs which maybe Naman can talk about.
Any experience in ondansetron minimizing perioperative hypotension following regional anesthesia? There are a few research, any experience? Dr. Senthil?
I don't know about ondansetron, but I just want to express on Dr. Devetia is very fond of non-invasive cardiac output monitors. I know there are a lot of things in the toys. I'll always say the toys in the market which give numbers. We don't know what the numbers indicate. The simplest, easiest, cheapest way anywhere else, the simple echocardiography machine, portable ultrasound. Now every anesthesia operating room has an ultrasound. If you put a echo probe, you can just do the VTI, you can see the Doppler, the suprasternal notch, that can give you very good indicators, and the true indicators. All the rest are imaginary numbers derived from some vague things and being FDA cleared and sold in India, I'll say in very brief.
Yeah, just a conclusion, anybody can contribute. Any algorithmic approach you want to have to treat hypotension? Of course, there are a lot of algorithms for every organ, but any 5 points, each one of you can say something concretely before we wind up.
I say if any instrument is easy, one is arterial line, one is echo machine.
Yeah.
Because
echo requires some training. Some training is required for
transthoracic echo is so easy. You can just diagnose effusion, you can diagnose contractily, you can see the VTI, you can see the VTI variation. You name it, you can get it, see the visual. Rest is all, extrapolating one to the other.
Yeah, Dr. Naman, who would like to just say any concluding statement before we wind up?
See, if there is a persistent hypotension, then we just have like two things, whether hypotension is associated with the ECG changes or not. If there is no ECG changes, patient is not showing any cardiovascular events, and then you can give the volume boluses. And as Dr. Devatia sir has said about the ERAs, enhancing recovery after surgery programs, where you can give either by having the change in the stroke volume, that is the delta stroke volume, or the stroke volume variation guided the volume therapies. And still if you have the hypotension, then you can have, meanwhile you can ask for the echocardiography and look at it, that whether the patient is hemodynamic compromised because of whether the wall motion anomalies or the hyperdynamic contractility or any other things. And then you can just keep on adding the vasopressures. Meanwhile, the metabolic corrections, the oxygenation corrections, and lactate. Of course, we don't give bicarbonate, but that will give us an idea about the post-operative outcome and so on. Yeah. So again, the volume, but not only volume, but at the right time we can add on the vasopressures, because the important aspect of using the cardiac output monitoring is to look at the stroke volume, systemic vascular resistance. Yeah. If we have this SVR with us, then we can understand whether we want to use the vasopressors or rhinodilators. So the SVR, if we have, then we can have definitely a better way of managing the hypotensions along with the volumes.
Yeah. Thank you very much. Actually, I was instructed by Dr. Bala to wind up the session in 40 minutes. Thank you very much, every panelist. And just 30 seconds, any question to the expert panelists you have from the audience? Another 30 seconds. Yeah. Incidence of myocardial infarction following profound hypotension following regional anesthesia. Diastolic hypotension.
So probably it could be
post. What I understand is this is asking after regional anesthesia, hypotension.
Following diastolic also is more, and any incidence of myocardial ischemia.
Well, whether it is regional or whether it is general anesthesia, the hypotension is hypotension. We need but definitely when the patient is having vasodilatation and the left ventricle afterload may be less, so may be able to work but the coronaries, they need the perfusion head. If the patient is having coronary artery disease and the perfusion head is lost, well, I'll just give an example. If you have a coronary artery disease and you're giving regional for hernia to this, it is good. But first thing is perfusion head has to be maintained. Whether you use vasopressor, vasophenylephrine or NOR-ADR, but I don't want to get into the debate whether to use phenylephrine or NOR-ADR, but it has to be given. The normal body generates these vasopressors in case of some problem. Why we are worried in not giving them? Why we only think of giving fluids?
So to conclude in one line, mean arterial pressure maintenance all throughout the surgery and perioperative period is of vital importance. Do not allow hypotension to occur, prevent it, and if at all you have it, treat it aggressively, and aim at maintaining not only the pressure but also perfusion and cardiac output. Thank you very much, everybody. I think probably we can take the questions during the tea break. Yeah. Paucity of time. I'm so sorry.
Thank you so much. Thank you so much
for
the expert panelists, and thank you, Dr. Sunil Pandya, for stepping in. Now I request Dr. Miodrag to